Now I'll invite Dr. Pradeep Ramulu to give his talk. Amit, can you share the slides of introduction of Dr. Pradeep, please?
Dr. Pradeep has been already introduced by our Chairman Scientific Committee, Dr. Partha Biswas. So Dr. Pradeep Ramlulu needs no introduction. He is one of the leading glaucoma practitioners in US, and he is actively involved in managing different pathologies which are concerned with the symptoms of glaucoma. So Dr. Pradeep is here to give a keynote address on evidence-based clinical practice guidelines for management of open-angle glaucoma. Over to you, Dr. Pradeep.
Well, thank you for having me today. You're able to see my screen okay?
Yeah, can see your
You're
slides.
not in
Yes,
full
we can, sir.
You're not in full screen mode. Yeah, there
Okay,
you go.
good. Thank you. So I'm going to talk some about evidence-based guidelines for the management of open-angle glaucoma. And as we'll see, we've seen a lot of cases that are very complicated cases. And so not all of what we talk about with regards to primary open-angle glaucoma necessarily applies to these complex cases. And I'll try and make those distinctions as we go through. I do have some disclosures. They're unlikely to play into what I'll be talking about today. So, I mean, there's a lot of international organizations that have put forth recommendations for how we treat and approach open-angle glaucoma. The All Indian Ophthalmology Society have done so, as has the American Academy of Ophthalmology, the World Glaucoma Association, several other organizations. And so I'd encourage people to go and look at some of these to get a sense of what things are like and how they ought to be treating their disease, especially as it relates to their local environment. So, and I think it's important to know that these guidelines that have developed all have some degree of evidence upon which they're based, but treating individual eyes and individual patients is complicated, and we can't really make all of our medical decisions purely on the basis of guidelines that have been published by various organizations. There's a lot of other considerations that we have to take into account when we deal with patients. And so therefore, going through cases as we're doing in this kind of symposium is very valuable, because we learn how to apply all these guidelines to the individuals that we have to take care of. So these are some of the reasons that evidence-based guidelines don't really work. You know, a lot of the studies that we do are really based on the status of the eye. And so we're dealing with one eye, but of course an individual has two eyes, and we have to put together a treatment plan that deals with both of them. A lot of the evidence that I'll talk about today has really stemmed from Western populations. And so many of the panelists have reproduced or extended some of that work to Indian populations. And of course, they've done very novel studies in Indian populations, may not have been done elsewhere in Western populations. But at the same time, you know, there's a need to understand whether the generalizations we're making are true across the world or just in some populations. There's, of course, you know, patients who we don't necessarily see or maybe see sporadically, who may be coming from a rural area. And so maybe, you know, the model of care where we can see them many times is not really applicable. And of course, we have to consider things like cost, you know, treatment burden, the ability of people to follow up, you know, complicated eyes, and new treatments, which is always complicated as well. So I think here I'm going to try and make more of a limited focus and really talk about the major principles of treating primary open-angle glaucoma and the studies behind some of these principles, and also highlight some areas where evidence is lacking. I think whenever you talk about guidelines for open-angle glaucoma, you have to really emphasize the fact that you need to know whether somebody actually has open-angle glaucoma, and you're only really going to be able to do this if you gonioscope the eye to know that the angle is open. So I think Dr. Friedman has shared some very nice, some pearls for based on his work, which tell you how to deal with angle closure and angle closure disease and angle closure glaucoma. And obviously some of the treatments that are involved in there, such as iridotomy or cataract extraction, play a much less prominent role if the angle is open. And if the angle is open, all of a sudden other treatments such as laser trabeculoplasty come into play. So really we have completely different or very, very different treatment paradigms for these two types of disease, and you're not going to know them apart unless you actually gonioscope everybody who you think may or clearly does have glaucoma. And you also have to keep in mind that the angle status can change over time. So just because somebody has an open angle at one point in time doesn't mean that they can't become closed later on. And so if you see a change in somebody's pressure or the disease stability, you have to think about whether the angle has become closed. I think there's three main elements that guidelines deal with. First of all is glaucoma present. And the second is treatment required, and then finally what treatment is best. And I'll try and deal with some of these in a cursory fashion in the time that we have. So first you have to decide whether glaucoma is present, and glaucoma is actually not so easy to define. This is the definition of the American Academy of Ophthalmology, where they say it's a chronic progressive optic neuropathy in adults with characteristic acquired atrophy of the optic nerve and loss of retinal ganglion cells. Of course, chronic means that you have to follow somebody over time, and we don't always have that luxury. And it doesn't really talk about, the different ways that you diagnose this optic neuropathy over here. In the Foster classifications, which are more meant for research, it actually says there has to be an elevated cup-disc ratio or cup-disc ratio asymmetry for that population, and also a visual defect, visual field defect that corresponds with that and is consistent with glaucoma. So, I think it's very important to really have a good training in how to analyze the optic nerve. There's a lot of different things that we can see, such as excavation or rim thinning, bayoneting, disc hemorrhages, nerve fiber layer defects, which all really need to be put together to decide whether somebody has a optic nerve which is consistent with glaucoma or not. The most common indicator that we use is the cup-to-disc ratio, but especially if somebody has a 0.9 or 1.0 cup, it's going to be pretty obvious. But when somebody has maybe a cup-disc ratio which is maybe suggestive of glaucoma, we can often be very misinformed just by going by cup-disc ratio. This is really nice work that Claude Burgoyne has done, where he actually looked at how clinicians judge the edge of the optic nerve head. And then he took serial OCT scans and figured out where the actual edge of the optic nerve head was. And what you see is that there's a very, very different tracing based on the green, which is the clinician disc margin, and the OCT Brooks membrane opening, which is the red. And I think the reason is that oftentimes there's a little overhang of Brooks membrane, which is completely invisible to the human eye. So really, we can't even say exactly what the cup-disc ratio is. In extreme cases, we might know that it's clearly indicative of glaucoma, but in interim cases, we don't know. And so I think what guidelines hasn't really picked up on yet is that really we need to be moving to OCT-based diagnosis for glaucoma. And OCT is very, very good at this. This is actually a study which was very nicely done by Felipe Medeiros' group, where they took a group with pre-perimetric glaucoma, which they defined as progression on color photographs, where the visual field still remained normal. And they actually found that average nerve fiber layer thickness did a really, really good job of finding these eyes. So in other words, if the OCT is abnormal in a meaningful way, it can actually predict who's going to go on to have actual progression. It's important, though, that OCT is interpreted properly. OCT is very, very prone to red disease or artifact. And so if you overinterpret it, you're going to have a lot of people who you're treating for glaucoma unnecessarily. On the other hand, if you interpret it properly, you can really identify a lot of early cases. So that is probably a lecture in and of itself. Visual field testing, while part of the disease definition, at least in research studies, is often difficult in people who haven't done a lot of visual fields in the past, and probably even more so if people are not very familiar with technology. This is one study that looked at mean deviation over the first set of 5 visual fields that somebody did, and you can see that there's actually a statistical upward slope of what people did over many, many visual fields, even out to 5 visual fields. And so people learn how to do it better, and so a lot of defects that you see earlier may go away later with repeat testing. The one thing that you'll notice in both of those definitions of glaucoma that I showed you is that intraocular pressure is not part of the definition. As Dr. Friedman mentioned, there's a lot of glaucoma that happens at lower eye pressures. In fact, this is from the Baltimore Eye Study, and 2 groups in whites and blacks. And they showed that for both groups, the 50th percentile, or the median intraocular pressure, was 20, which would not be high if you took a pressure cutoff of 21 as being abnormal. And furthermore, there's a lot of people who have high intraocular pressures who don't have glaucoma and don't go on to glaucoma. These are data from the ocular hypertension treatment study, or the OATS study, which show that over many, many months, out to 84 months or 7 years, that the percentage of people who develop open-angle glaucoma when they didn't have it at the beginning, when they just had a high eye pressure, was not very high. This looks bad, but if you look at the y-axis, the percentage is only 15% in people who were observed and not treated. And if you treated them, you cut that down by about a half. But frankly, in both groups, there was not a lot of progression even over a very long period of time. And I will note that you shouldn't really overinterpret the ocular hypertension treatment trial. The maximum intraocular pressure included was 32. There was only open angle glaucoma, no pseudoexfoliation or other secondary causes. And as you see in all the cases that have been presented, you have a lot of eyes where the pressure suddenly went high and the visual field got worse very, very quickly. So they were picking people who they knew had high eye pressures for many, many years probably and were found incidentally. And so that scenario is very different than somebody who comes in with a suddenly high pressure. From a secondary cause, those eyes are most likely going to go on and get glaucoma. Is treatment required in glaucoma? The answer is that not all open-angle glaucoma eyes must be treated. There's really a significant set of cases in which observation is reasonable. This is data from the collaborative normal tension glaucoma studies, which shows that normal tension glaucoma does not progress very much, if at all, over many years of follow-up in many eyes. And so it's only about 40% even at 7 years. When normal tension glaucoma progresses, it does so pretty slowly. This is a little bit of a complicated figure from one of their publications. But if you look at the dots in the oval, it shows that very few eyes progressed at a mean deviation slope of more than 1 decibel per year, what we might consider fast, and most of them were very, very slow. And in fact, these few eyes that progressed very quickly were very imprecise in the estimate. In other words, there was a lot of variability in the visual fields, and so we can't even say for sure that they really were progressing faster. And so intraocular pressure is helpful in lowering, is helpful in normal tension glaucoma, but not completely. So in their clinical trial, they found that, that it did seem to help with visual field progression as an outcome, but only after they corrected for the effect of cataract. So in other words, if you include cataract progression, there was really no benefit to treating in this low pressure group. On the other hand, the European Manifest Glaucoma Trial, or EMGT, showed a very clear benefit to treating open-angle glaucoma. So you see a lower number of eyes that progressed to treatment, although even a lot of the eyes, even in the treated group, progressed. That's because this group actually didn't set a target pressure for when they were trying to lower the eye pressure. So it actually kind of emphasizes that if you're going to lower the eye pressure, make sure you lower it a certain amount, otherwise you're not going to get very good results. What they did is they simply gave all eyes the same treatment with betaxolol or laser trabeculoplasty. And in many eyes, the IOP lowering was modest, and so many of them progressed even in the control group. This also shows that they had 3 groups of people who they described: the normal tension, high tension, and pseudoexfoliation. And as you see in the black, in the untreated group, many of the pseudoexfoliation eyes progressed very, very quickly, followed by a moderate number in the high tension group, whereas the normal tension group did fairly well. If you actually look in the group with normal tension glaucoma, who was younger, and younger is not that young, it's less than 68, the average rate of progression is 0 decibels per year. So this kind of reiterates the fact that in a low pressure group, you don't necessarily need to treat people, you can watch them at first. And if you compare this to the pseudoexfoliation group, the progression rate is much, much faster. This is a study done in the United Kingdom, which shows that latanoprost specifically prevents glaucoma progression. But even here, there was a slow pace of glaucoma progression, and they couldn't detect any difference in quality of life between the treated group and the placebo group. And they only really noticed a difference between the placebo group and the treated group when they looked at the stables and the progressors and their quality of life. So in other words, even if you don't treat a lot of people for a short period of time, their quality of life doesn't worsen. What treatment is best? The collaborative initial glaucoma treatment study found that IOP lowering is better with trabeculectomy than medical treatment. On the other hand, there was no difference in the visual field. So it may be enough in initial glaucoma to get the pressure down to around 15, 17, and you don't necessarily need to get it very low. Oftentimes you can have very good results. There was, however, more trabeculectomy in the treated eyes. And so if you're trying to do a trabeculectomy and sending somebody out to a rural area, you have to anticipate that they may need to come back and they may live several years. without getting their cataract addressed, which may not be the best thing for them. The advanced glaucoma treatment study had a very complicated treatment algorithm, but I think it's well known for finding that in this group where all of the eye pressures were less than 18, they really had no progression. So in other words, even in advanced eyes, if you lower the pressure to a consistent level, you can do very, very well in terms of your outcomes. The idea is re-emerging with the light trial that trabeculoplasty is a good initial therapy, but this is not a new finding. So this is actually a study from now 25 years ago, showing from the laser glaucoma trial, where if you initially do argon laser trabeculoplasty, you have lower intraocular pressures, better visual field, and better disc status. And so not surprisingly, they redid this study 25 years later, and they found that they have better intraocular pressure and better visual field outcomes. And so that's not a new finding. So I'll stop here and we can take questions, or we can just go down to the cases and maybe discuss how to apply some of these guidelines to individual eyes and individual patients.
I think that was a very nice and exhaustive presentation covering all aspects of open-angle glaucoma. Thanks to Dr. Pradeep for delivering such a nice talk on open-angle glaucoma. Now I'll request our member scientific committee, Dr. Sonu Goyal, to introduce the next speaker, Dr. Digvijay Singh. Dr. Sonu Goyal, please.
So thank you. I'll now introduce Dr. Digvijay Singh. He'll be talking on progression despite normal IOP, more than meets the eye. Amit, can you please?
Yeah, I'm just sharing the screen.
Yeah.
So Dr. Digvijay is the.
Can I interrupt you? I think there is a question for Pradeep. Let Pradeep answer this.
Yeah.
Yeah.
It's there in question answer. Like Pradeep, as per OHD, I think NNT would be 20, which is not ideal to start treatment. NNT can be reduced by selecting high risk group. That is a question to Pradeep from Dr. S. Vasanta.
Yeah, I'm not sure what NNT is.
Number needed to treat based upon the risk factors.
Yeah, I mean, I think that's a very good point. You know, that we often don't think of the number needed to treat, but when you think of things that way, you really have to treat a lot of eyes with ocular hypertension to see a positive benefit. And so I think it really does argue quite strongly for following people, except in those who are in the very high risk group. And I didn't go into all that, but if in the group which has thin corneas and very high baseline pressures, or the group who might be younger and have to live with this pressure for a very long time, those are the individuals who you might consider treating.
Okay, good. So you would prefer to treat if there are more risk factors rather than to treat them. That's what she wanted to have clarity on.
Yeah, I watch most of those eyes, and I think David probably would make a similar argument for laser iridotomy, that the number to treat over there is even higher. So you might have to treat hundreds of eyes to see positive benefit in one.
Okay, thank you.